Welcome to another episode of the PFC Podcast. The opinions you hear are ours and doesn't necessarily reflect anyone else's. Now on to the podcast.
Welcome back to the PFC Podcast. This is Dennis, and today I have a special guest. We have none other than Dr. Andrew Kapp talking to us about a subject that is near and dear to all of our hearts, the how-to guide of resuscitation with whole blood. On an operation in southeast Afghanistan, a SEAL platoon accompanied by ANA started receiving coordinated mortar, RPG, and small arms fire. Patient number 1 was hit by a mortar round detonating at his feet. The patient was found with a full amputation below the left knee and a partial amputation below the right knee. Fragmentation injury over the patient's chest with large lacerations to the lower extremities. Patient number 2 received a GSW to the abdomen and to the left leg. The first responders on the scene provided hasty tourniquets while under mortar fire. The members dragged the patients to a covered area where the medic began to deliver treatment. Patient number 2 was conscious initially, but has gradually lost consciousness. After suppression of enemy fire by fixed wing, the team was able to withdraw and begin more definitive treatments. These are initial vital signs. Patient number 1, blood pressure 79/57, heart rate 120 strong and regular, respiratory rate 20 deep and regular, GCS 13, E4, V4, M5. Patient number 2, blood pressure 65/52, heart rate 140, weak and regular, respiratory rate 22 deep and regular, GCS 9, E2, V3, M4. Neither SpO2 or temperature were monitored.
So, Dr. Kapp, with this first patient, the controlled hemorrhage patient, bilateral amputations, but we have hemorrhage controlled. So, could you start walking me through your decisions on a resuscitation?
Sure. And first of all, thanks very much for having me on your program. So, in considering a patient like this, what you really need to assess is, first of all, does the patient need resuscitation? And when we look at the scenario, we have pretty severe injuries involving significant blood loss, and the patient's vital signs have taken a turn for the worse to demonstrate signs of shock. So clearly significant hypotension and tachycardia. And so when you have that kind of a significant blood loss, you're at the risk for developing shock and coagulopathy. This is really a patient who untreated will suffer significant morbidity, if not mortality, even after controlled hemorrhage, if they don't receive resuscitation. This patient in the, who's suffered a massive injury, a lot of blood loss, and is now hypertensive, needs to be adequately supported. So how are we going to do that? The first thing, as I've sort of sketched out here is, the obvious thing is to replace the lost organ function. So the number one choice for how to approach this patient would be to use blood, in this sense, whole blood, which can replace all of the different functions of the constituent parts of blood in one product. So that's your best option. Now, if you think about the typical pre-hospital care environment that we encounter in the military, blood's not readily available in large quantities, and so in the ideal world, you would have enough blood to completely replace the lost volume and completely restore homeostasis. If you can't do that, there are other strategies we use to compensate for that for that lack of capability. So one thing is, do you need to completely restore blood pressure to where the patient started off? And so, we teach this practice of hypotensive resuscitation, which is mostly aimed at avoiding rebleeding by stressing the clot with increased blood pressure. If you have a scenario like this one where the bleeding is controlled by tourniquets, which is, of course, the very first intervention we should always go towards is stop the bleeding, right? So when that's possible in, extremity injuries and you can get good hemorrhage control, that's great. So we're not as concerned with this idea of popping the clot. And I will say, by the way, that essentially all the literature on popping the clot that's, obtained in the clinical environment is really done in the context of crystalloid-based resuscitation, which worsens hemodilution and potentially increases bleeding. And so if you're using blood to resuscitate, it's not entirely clear that the same sort of thresholds apply. So we've typically taught, aim for a systolic blood pressure of 90, and that will get you decent enough resuscitation without increasing the risk of rebleeding. The impact on the patient's physiology of hemorrhagic shock is determined by the degree of shock and the duration. So, if you go from very poor perfusion due to extremely large blood loss, and bad ischemia with serious coagulopathy, and you keep that patient obviously at that very low level, you don't have very long to keep that patient alive. They're just, that's not compatible with life. So if you get them to not so bad shock and not so bad coagulopathy, is that really good enough? And that's where things really depend on your clinical scenario. If you're the pre-hospital provider, put that patient on some kind of Casovac platform, Medevac platform, get them out of there and get them to a higher level of care very quickly, that's probably good enough for the initial phase of care. However, if you're in a prolonged field care scenario, well, now you're talking about dose of shock. So you went from bad shock to less bad shock. But if you increase the time that they're in less bad shock, you're still going to end up with pretty significant morbidity and potentially mortality. So, renal function being an example of, morbidity that we have encountered in the past. So in the Korean conflict, one of the things we noticed was we had a lot of patients who received Korea was really sort of a great example of prolonged field care on a massive scale, because we had very long evacuation times typically. We did a pretty good job of moving blood far forward. Patients typically received about half of their total resuscitation in blood products that they got overall in their care prior to ever reaching an MTF. So, these patients who might get a massive transfusion of 20 units of whole blood, they would have gotten 10 units prior to ever making it to the MTF typically. However, this is over like a 4 to 6 hour evacuation. And, in a patient like the one we're talking about now with controlled hemorrhage, that might be more than enough and they might be just fine. But in the setting of ongoing hemorrhage, if they're hanging around a blood pressure of 80 or 90 systolic, that might not be enough. And what we saw a lot of was, frankly, a lot of renal failure and need for dialysis. So this gets to the point of, okay, you've exhausted your blood supply. What are you going to do now? And in general, if you look at the TCCC guidelines, the order of preference in resuscitation approaches is essentially how close to the underlying organ function can you get with the products you have. So whole blood's at the top of the list because that's exactly what was lost, and so you're giving it back, and that's great. Next would be component therapy that kind of approximates whole blood to a lesser and lesser degree as you sort of don't have the various components. And then you get into, okay, I've got no blood, now what? So the recommendations at that point become less optimal, and we get into the question of what about hetastarches as colloids versus crystalloids. One thing that is not on the TCCC list, but that I do think is worth discussing, is albumin, which has been widely used in resuscitation since World War II. when it was used in the pre-hospital setting, sort of interchangeably with freeze-dried plasma, actually. So the problem with crystalloids, regardless of their composition, is that they basically are not going to stay intravascular for very long. You can restore somebody's blood pressure back to normal with any crystalloid you like, and if they've suffered a large blood loss, what's going to happen is their blood pressure is going to go back down pretty quickly over the course of perhaps a half an hour or thereabouts, because all that fluid is going to leak back into the extravascular space. And the more inflamed they are and the more sort of shock they've suffered and the more leaky their vasculature is, the more that effect is going to be accentuated. So, it doesn't buy you very much time to use crystalloids, regardless of the type. So starches stay intravascular, which is why we adopted them. The problem with starches is that, you really don't have starch floating around your bloodstream, and your body really has no effective way to deal with that, particularly when it hits the glomerulus in the kidneys. And there's no question that the entire class of starch-based colloids causes renal injury. And this has been amply demonstrated not only in trauma patients, but in cardiac surgery patients and in other surgical patient populations. And the FDA has issued a black box warning on all heterostarches, basically, or all starches, essentially saying, don't use these in patients with, at risk for renal injury. Don't use in the setting of lactic acidosis. Don't use in any patient with a coagulopathy, because the starches interfere with the functioning of the coagulation system and with platelets. So, the evidence is pretty clear that that starches are really suboptimal for resuscitation in the patients that we're talking about. And honestly, I'm not sure that they would be an optimal choice in any patient population. Now, obviously, dose matters. The more starch you get, the more at risk you are. But are there other options? And so albumin turns out to be, the main protein constituent of plasma. And it has, of all the colloids that have ever been studied, it has the least effect on coagulation, in part because it's supposed to be there. If you give a high concentration of albumin, such as 25% albumin, it will cause volume expansion by pulling fluid out of the extravascular space and into the blood vessels. That causes hemodilution. So there's always a hemodilution component to any colloid that you use, including albumin. However, albumin is basically the least bad. Why don't we use albumin, and why wasn't this included in the TCCC recommendations? Basically, there was a study performed in Australia called the SAFE study a few years ago, in which there was a large cohort of patients, some of whom had TBI. And in the patients who received albumin as their primary resuscitation fluid over from the time of admission all the way through their entire ICU stay, so it was, if you were randomized to albumin, that's all you got the whole time. Those patients did worse if they had TBI. And so this has been interpreted as, if you have a TBI, don't ever give albumin. I think this is an overinterpretation of that study. It's a small cohort, retrospective. And on top of that, they used 4% albumin. And there are animal data that suggests that actually a higher percentage of albumin avoids any of the potential problems with leakage of albumin into the essential consideration is that, or thought is that albumin might leak into a leaky blood-brain barrier into the brain and pull tissue fluid into the brain and cause more edema. If you use a hyperoncotic albumin preparation, anything over 10%, that effect seems to be reduced. But regardless of all this, we're talking about the pre-hospital setting where, again, dose of colloid is going to be limited no matter what you give. And so albumin in limited doses is less likely to cause problems in the thing that's going to kill you most acutely, which is coagulopathy and bleeding, and won't cause renal injury. And in fact, is protective to the endothelium, the lining of the blood vessels. So for all those reasons, I think that albumin is really something we should be considering in, future discussions of replacing the starches, which clearly have been shown to be suboptimal. So blood first, in whatever type you can get it, moving down the pecking order into colloids, and then crystalloids have a role to play. So the reason crystalloids got into trauma resuscitation in the first place was actually because if you think about it, if you bleed and you drop your blood pressure and you move that fluid out of the extravascular space into the blood vessels, and then you control bleeding and you add some blood back to where your blood pressure is normal, you've refilled the vascular compartment, but you haven't refilled the extravascular compartment. And the kidneys in particular are very sensitive to this, and this contributes to, the incidence of acute kidney injury in patients who have suffered hemorrhage. So, Tom Shires, had explored this question pretty thoroughly, several decades ago and made this point to people and said, after you've resuscitated with blood, you need to give back a little fluid to refill the extravascular space and keep the kidneys happy. Well, people have sort of put the cart before the horse because it's easier to give fluid than it is to give blood in the pre-hospital setting. And so we've kind of assumed that, most patients don't suffer very severe injury and a little bit of fluid is okay, and it's good enough for the vast majority of patients, which is probably true in the civilian environment, but in the military environment where penetrating trauma and different mechanisms of injury cause more significant life-threatening hemorrhage, it's really not good enough, and it's actually harmful if you cause hemodilution with excessive crystalloid use and then more bleeding. One thing about the crystalloids, just if you're talking about different types to use, so the only one that's commonly used that actually contains calcium is lactated ringers, and it's considered a somewhat balanced crystalloid in that its composition is a little bit closer to the electrolyte balance in plasma than normal saline, and it's got a pH of 6.5. It's a little bit less likely to cause acidosis and so forth. The tricky part with this is that, of course, if people have only one point of vascular access and they're infusing blood and then maybe chasing the blood with medications and using LR as a carrier, you do have the potential to introduce blood clots into the line due to the calcium in LR. So it's important to remember that the only two fluids that are actually compatible with blood product administration are Plasmolite A and normal saline. So between the two of those, Plasmolite A is really designed to be much closer to the actual composition of blood from an electrolyte standpoint, and it's got a normal pH of 7.4. So that's really the preferred product compared to normal saline. Normal saline, I think it's important to remember, was designed to treat cholera, where in fact the physiologic problem is loss of salt through, bacterial toxin mediated salt wasting in the gut. So it's actually not a bad treatment for cholera, although we now treat cholera mostly with oral rehydration solution anyway. But the point is that you can understand the background in which normal saline kind of came into use for patients who were suffering severe diarrhea in a cholera setting, but it just doesn't make any physiologic sense whatsoever to use normal saline in the setting of hemorrhagic shock. In part because you end up with a pH of 5.5 roughly going into the patient who's already developing a metabolic acidosis, a lactic acidosis. So you're just making that worse and causing a hyperchloremia. It's really just a suboptimal product. So if you want to minimize your packing issues, which are always a major concern for, the pre-hospital setting and what medics can carry, I would get rid of the saline. I would not use LR. I would use Plasmolite A. That's the most physiologic product that's going to help you restore homeostasis in your patient. It's compatible with blood. And you really won't get into trouble using that. All that said, I made the point about calcium. And I think calcium is something that we've really neglected, except perhaps in the sense of don't mix LR with blood products. But it turns out that patients, we've taught for a long time that we really need to worry about hypocalcemia when we're giving saturated blood products in large quantities. And most massive transfusion protocols will include some, reminder. Think about checking ionized calcium during the resuscitation, or to give empirically calcium during the resuscitation after perhaps 4 to 6 units of calcium, after 4 to 6 units of saturated blood product. The problem with that approach is that it neglects, the important observation that actually patients who have suffered significant hemorrhage are already developing a lactic acidosis. Why is that important? Well, lactate binds calcium. In addition, if you've had muscle damage, like for example, this patient who's had these, partial or complete amputations of the lower extremities, with a lot of, soft tissue injuries as well, muscles full of phosphates, and phosphates, negatively charged ion that will also bind calcium. Calcium phosphate is in your bones, right? So, basically, you're chelating a lot of ionized calcium. And so, in a study done in the UK and published just recently, they looked at the incidence of hypocalcemia, ionized so low ionized calcium in trauma patients admitted to the ED, and 50% of them, right out of the box, were hypocalcemic. And then administration of as little as 1 unit of any saturated blood product, so any blood product basically, made 90% of them hypocalcemic. So waiting till they're super hypocalcemic after 4 to 6 units of blood products is not optimal. And by the way, even if you only had 2 units of whole blood, let's say, and nothing else, and you gave him that, and then you gave him some Plasmolite A or normal saline, well, now you are going to actually further hemodilute them, and you're going to dilute their calcium. So the bottom line is that between dilution and chelation of ionized calcium by lactate and phosphates, you are going to see pretty profound hypocalcemia. And how does that manifest itself? I mean, if you read about hypocalcemia and you hear about all these things like, neurospasticity and cardiac arrhythmias and so forth, you may not actually observe those things in a patient who's perhaps lost consciousness and who's, profoundly weakened by shock and so forth. And you may not notice some of the signs and symptoms just because of all the other distractions on the battlefield. However, ionized calcium is critical for maintaining cardiac output. And so, anecdotally, we hear from surgeons at the receiving MTFs who will tell you that they have taken care of many, many patients who have come in in shock with ongoing resuscitation, and then who have been fully resuscitated, given, 5-10 units of blood and gotten blood pressure back up, and things are looking okay, and then they crash. And sometimes that's, of course, due to, complications of intubation with paralytics and so forth, dropping blood pressure. But even in spite of it, not counting those, those problems, you do have these cases of so-called irreversible shock. And interestingly, this was also observed back in the Korean War, and the intervention that was most commonly effective at reversing that state was giving more calcium. So when we take all that together, we know the patients are hypocalcemic, from the get-go as they're going into shock, and we're going to make them more hypocalcemic by the necessary interventions to restore blood function. It makes sense to give calcium early, and not wait until you've given 4 to 6 units. In fact, if you're thinking about giving blood to a patient, you should be thinking about giving them calcium. So there's a whole bundle of interventions that really come together very early in a major resuscitation that we have to keep in mind. Obviously, hemorrhage control, getting vascular access or IO access, and then, as you start to think about how to structure the resuscitation, the most important thing to get on board is obviously the blood if you have it. But other things that need to come very early, like as you're giving blood, or if you're waiting for the blood to show up, or you're trying to set up a blood warmer, you can always give calcium first and try to reverse that hypocalcemia while other things are going on, because that's a relatively quick intervention. Right along at the same time that you're giving tranexamic acid. And you can use Plasma-Lyte to flush these things through, and there's no problem. And then, give the blood as soon as it's available. Or freeze-dried plasma if you have that. Freeze-dried plasma, by the way, is really just plasma at the end of the day, right? It's not whole blood. So if you have whole blood immediately available, you should lead with that and then sort of top the patient up. Like if you have this scenario where, you kind of got them to systolic at 90, hemorrhage is controlled, but they're still not doing great, and you need other things to give them, the next thing to give them would be something like freeze-dried plasma. And then only going to, albumin or crystalloids or whatever, after you've sort of exhausted those options. Now, you have one patient in front of you, you should take care of that patient. If you have multiple patients in front of you, or a setting in which you're hesitant to use all your blood products on one person, that's an individual judgment call based on the scenario. But, in an ideal world, if you just had one patient, you'd sort of go down all the blood products first and then go into the crystalloids, and or, albumin, after that. But calcium very early. Yeah, go ahead.
I did have one. You had mentioned calcium, TXA, while you're waiting for your blood products. A lot of units, they have little golden hour boxes that have blood products with them. So right now in the TMAPS guidelines, it says to give TXA over 10 minutes. Now, I personally think that it's smart to get 2 lines and do them both simultaneously, your resuscitation and give TXA. But right now they're really just training using 1 line, giving the TXA over 10 minutes, and then giving a resuscitation after that. What do you think about that technique?
I would try to get the first gram of TXA on board immediately, and then get some of these other interventions going before you give that. I wouldn't, if you had blood immediately available, I would not wait 10 minutes while, to infuse. Well, so actually, I see what you're saying. There's the whole 10-minute infusion of the first unit, and then followed by the 8-hour infusion, sort of slow drip thing. I would definitely not wait for the for the infusion to begin, definitely give all the other interventions before starting that long infusion. A 10-minute infusion of TXA. This is a question that comes up again and again is must we give it that way? Can't we give it faster? I've seen people give it faster in the operating room and so forth. We base our recommendations for TXA administration off of the CRASH-2 trial, which is the primary clinical evidence for its effectiveness in trauma. It is widely used in pretty much every surgical setting you can imagine for hemorrhage control also, and given differently in those settings, both in terms of dose and rate of administration. So you could imagine changing those recommendations, and actually the DoD has sponsored a couple of clinical trials to study dosing and rate of administration, and so we should have results back from those studies in the next year or so. So those recommendations may change, but faced with this controlled hemorrhage patient, if you're really pressed for time, with somebody who's, exsanguinating in front of you and really hypotensive with uncontrolled hemorrhage, I would probably lead off with the blood products and try to boost volume a little bit so you have some perfusion, and then give the TXA after the blood products. I think urgency does make a difference, and I think the real decision point there would be, is the hemorrhage controlled or not? Because if it's leaking out really fast, and they've already lost a lot of blood, there's only so much time you have for brain and cardiac ischemia. So waiting 10 more minutes for TXA to infuse is probably not the right answer. If they're really in profound shock, I think I would give the blood first. The key teaching with TXA is that it should be given within 3 hours of injury, which doesn't necessarily mean it's the absolute first thing that goes into the patient. You sort of have to look at the patient and say, is this guy dying in front of me instantly right now, from uncontrolled hemorrhage? And you got to support their physiology best you can with what you have to get them to not immediately dead. Right?
Yeah, I think part of the problem is, for whatever reason, like when I went through the course, it was, bilateral IVs, 2 liters and slam them. And then when they went away from it, like everybody seemed to have forgotten how to get 2 IVs. Like it seemed like, that's what happens in the emergency room. Why not give 2 IVs, run that stuff simultaneously? He needs the resuscitation. TXA is not going to help him right now. If his artery is squirting blood, TXA is not going to be the thing that fixes that. TXA is something that's going to help him later on, but he needs resuscitation right now and the calcium right now. Why not run those 2 things simultaneously, buy you time so that TXA can have an effect and actually, get to work?
I agree. I think getting more points of vascular access allows you to do more things simultaneously. And, in an ideal world, you'd have a big enough team taking, that's why we have a trauma team in the ER and, all these interventions happening at once. Nobody's waiting to give blood products and TXA. They're all going in simultaneously in a trauma center. So how can you best stage that if you're all alone? Maybe get an IO first and then start blood going through it, because obviously if they're so vascularly depleted you can't get an IV, but if you can get some blood going through the IO, then they'll plump up enough to get an IV, and then you can put the TXA through the IV, and then after the unit of blood you can give them some calcium, and then next unit of blood and so forth. I totally agree that you need to think about it in terms of there are biochemical things you're trying to do, like make them clot better. So TXA, which is not really making them clot better, it's just making their clots more stable. But the calcium, antibiotics, all that other stuff. But at the same time, if there's no blood circulating, then nothing is happening, right? So you have to maintain the volume aspect and the perfusion aspect, but without the hemodilution and all that. So the blood going in kind of simultaneously is the most optimal scenario you can do, and more access is the way to do that. The uncontrollable hemorrhage patient, everything I said previously applies. The difference here for the uncontrollable hemorrhage patient is that you basically have an ongoing titration issue to deal with, which is because you can't control the hemorrhage, you got to support the physiology with enough volume that doesn't make the coagulopathy worse, and therefore increase the rate of bleeding. But not so much that either you burn all your supplies too quickly, or that you cause more rebleeding due to high blood pressure. Lower the blood pressure, the less the bleeding. There's no doubt about it. That's very clear. And below a blood pressure of 80, it's hard to see much bleeding. Certainly venous bleeding tends to drop off quite a bit. So I think that's your main challenge here. In terms of decision points, again, this is where getting the initial physiologic stabilization performed urgently is really critical. You've got to get some degree of blood pressure response. And vital signs are not the best the best indicators of physiologic status. Unfortunately, they're pretty blunt tools, and they tend to lag actual changes in cardiac output and so forth. Point is, though, if you're already hypotensive, you're there. So it might have been possible to anticipate that with a better set of diagnostics earlier, but if you're already there, you're already there. And the answer is you have to try to reverse that to some degree. And certainly you can't practice hypotensive resuscitation without measuring blood pressures. So, if you know that you're trying to target something in the 80 to 90 range, you need to be checking blood pressure, or some degree of perfusion index, whether it's radial pulse or carotid pulse or mentation, and trying to keep track of what you've put in and how much you have left to give, and how the patient's responding. I think those are some of the critical decision points there. Choice of fluids, all those things are essentially the same. The real difference being that you're going to tolerate a lower blood pressure because you have to.
At some point, you're going to have to decide, is it safer to keep them at a lower blood pressure, or am I going to be forced to push it maybe a little bit higher? Hopefully he made a clot strong enough that it'll hold it. But at some point I'm going to have to test this, because his kidneys are going to die if I do not. At what point would you start test the strength of the tank?
Well, if you think about clotting dynamics, if you just took whole blood in a glass tube and let it clot, non-citrated whole blood, or recalcified whole blood, and just let it clot, it will at first form a sort of a soft clot, and then it will retract, right? And that retraction is where you really generate the greatest strength in the clot, and also that retraction reapproximates wound edges to close wounds. So that whole process takes about at least a half an hour. from the initiation of clotting. And to fully harden and mature, it can take as long as an hour. So, and that's under relatively ideal circumstances. So I think, if you're looking at testing the strength of the tank, I would probably give it at least half an hour to an hour before trying to push the blood pressure a little higher. I think if you do it before then, you have immature clots that are more likely to let go. That would be my, again, without surgical intervention, if you're just thinking about the strength of the clot, isolation, it takes that long, half an hour to an hour, for a clot to mature enough and contract, to sort of reach its maximum strength. And that's, by the way, in a setting where you don't have ongoing fibrinolysis on a massive scale. So if a patient's been in shock for a while, you may never get a good, solid, retracted clot in some patients. I'm talking about normal patient blood, that's what it takes. So, this has to be individualized to some extent. The reality, unfortunately, is that if they are not forming clots by the time you start taking care of them, this is going to be very hard to have a successful outcome. But drugs like TXA can be very helpful in that setting. So it sort of prioritizes, TXA as an antifibrinolytic.
I think by that hour, if you've gotten them that far, I would imagine TXA is already at least beginning to start to work. And now we can, at least knowing what the baseline of a clot formation is, we can at least start attempting to test the water. And if he responds well to it, then okay, maybe we can just go just a little bit further and a little bit further until we get to a more normal tensive patient who maybe is making urine now or mentating better, achieving those outcomes that we looked at with the controlled hemorrhage patient.
Absolutely. One thing about TXA's onset of action, its onset of action is immediate. The issue is whether the patient has begun to have clinically significant fibrinolysis or not. And so in some patients that may not occur immediately, and it's more likely to occur the longer they're in shock. So, but the drug is it doesn't have to be converted from inactive state to active state or anything like that. Its onset of action is immediate. The question is whether the patient whether you're sort of giving it almost prophylactically, to prevent a sort of normal to maybe slightly enhanced fibrinolysis from getting out of hand. But if they already have active, clinically significant fibrinolysis that's preventing them from forming stable clots, it will start to act immediately. As long as there's enough perfusion to get it to where the bleeding is occurring, right? Because if there's no blood pressure, it's not circulating. Right, so it has to actually circulate to get to the wound site.
I think this is a good place to stop, Dr. Kapp. I want to thank you for talking to us about resuscitation, and for the listeners out there, all of us at the PFC Working Group thrive on conversation, so make sure to put your questions or comments in the show notes below. As always, this is Dennis for the PFC Podcast, out. That's another one for the books. Now take the challenge and go to the website, www.prolongedfieldcare.org, and answer the questions linked to the podcast. Test your knowledge on the scenario and keep an eye out for the roundtable talk where we answer the questions and find out what an expert would do in the exact same scenario. I'm Dennis with the Prolonged Field Care Podcast, out.